Hi, I'm Tamara, and this is TELUS Talks with Tamara Taggart. Hi, everyone. Today we are speaking with Dr. Samir Sinha, a passionate and respected advocate for older adults. He's the director of geriatrics at Sinai Health and the University Health Network in Toronto. So nice to see you, Doctor. Is it okay if I call you Samir?
Absolutely, Tamara. Yeah.
Awesome. Okay. I'm really looking forward to this conversation because, during this pandemic, we've been hearing so much about seniors and older Canadians and long-term care facilities. Where is your focus at when it comes to this pandemic?
My greatest focus at the moment is just making sure that older Canadians are feeling safe and supported because, whenever we have a pandemic and whenever we have new viruses and infectious diseases circulating, we know they tend to go after people who actually have weaker immune systems. And that tends to be young children whose immune systems are just developing, hence why they need vaccines. We talk about older adults who are experiencing more what I like to call mileage. So your immune system just weakens as you get older. And then we're talking about adults who actually might be living with chronic health conditions. So things like diabetes or obesity, for example, which actually increase your risk of dying from COVID-19. But if you think about the Spanish influenza, the big epidemic that we often kind of refer back to just over 100 years ago, that was actually an interesting epidemic because that actually ended up really going after young children, killing lots and lots of young children, didn't really have much of a negative effect on older people. And now we almost have a complete opposite situation where it's not that COVID-19 can't harm young people, for example, it certainly can. But when you actually look at the overall case fatality rate, this is a lot more deadly than the flu, if you will. It's 10 times more deadly than the flu. Yet, when we think about the rates at which this actually kills older people, the average person in our population has a 1% to 2% chance of dying from COVID-19. But when you're in your 60s, your 70s, your 80s, and 90s, that risk goes from 3 to 8 to 15 to 25%. And we were seeing rates of death as high as 37% for people living in our long-term care homes across the country. So it just tells you how vulnerable our older population has been and why you could appreciate that we're all a bit nervous about older people in our lives. And frankly, Tamara, I think it's also we're all going to age if we play our cards right. And so you're wondering, well, when that next pandemic hits, am I going to be one of these statistics as well? Or how do we actually get things right so everybody can do well together as we try and navigate our way through this pandemic?
How we look after our older generation and those of us that hopefully will get there one day too, is that the problem? How we look after our seniors?
Yeah, well, I think that really is the first question is how do we look after older Canadians and how does that actually impact on what's actually happening? And I think the key is if you think about is long-term care the problem? Well, I think in Canada there are significant issues, if you will, in terms of how our homes have been organized and supported throughout this pandemic. Because if you first of all go around the world and you go to places like Singapore or Hong Kong or Taiwan, for example, or Korea, they've had significant rates of community spread, yet you could count the number of people who've actually died from COVID-19 in these settings, with the finger, if you're with your own fingers, for example, very few deaths, partly because in certain jurisdictions, they realized that these were places that housed incredibly vulnerable people who live in close proximity, who are often all needing a level of care, and often many people are receiving care from the same individual. So all of those things make this a perfect a place for if COVID-19 gets in, it can wreak havoc. And we've seen how it's actually been responsible for 80% of our deaths in Canada so far have actually occurred in long-term care and retirement homes compared to, and that's double the international rate and average. But but way higher than what we've seen in countries, some of the ones I just mentioned, where there was a huge amount of effort taken to actually make sure that those homes have extra staffing. They have more solid infection prevention and control supports. And in Canada, we already seen this story play out in British Columbia, where their chief medical officer of health followed the evidence. understood, the science of COVID in these settings, and asked the government to take extra precautions and steps early on, which worked pretty well in BC. When you actually look at our COVID-19 deaths amongst older Canadians, we've seen that you have a 73.7-fold greater chance of dying from COVID as an older person during the first wave if you lived in one of these care homes versus if you were actually living in your own home in the community, where it's actually a lot cheaper to provide people home care so they could stay there in the first place. So this really speaks to some of the challenges that we've really had as we look through kind of what's evolved in Canada versus other parts of the world.
So are we, is that where we're going wrong here? We have this idea that when you get older, you're just going to go live in a long-term care facility anyways, and whatever happens, happens?
Yeah, so I mean, this is a complex issue, and I think there's a few different things that I want to unpack here. Number one is kind of we always use this notion about why in Western society do we care less about older people? I mean, why do we seem to have more societal ageism where we think about this older generation as kind of a less useful cohort? For example, they're no longer driving our economy, if you will, and therefore, what's the use of having them? And especially those people who end up living in our long-term care homes. And I want to just point out something, Tamara. I actually have been taught by my colleagues to not say facility, but to say home. Because fundamentally, at the end of the day, these are actually people's homes. But we actually think about them in our society as facilities. And by calling a home a facility, you're dehumanizing the actual people who are there because they actually need it. So it just talks about this notion of societal ageism and how we look at these places as facilities rather than the homes which they're actually meant to be. But I think part of this, it's complicated. Number one is we actually, in our society, we don't have as many people kind of living, in the same community as where they grew up with. So we have people less likely to be living in intergenerational communities. And part of part of our success as a society, having a vibrant economy, is that we can now live in different parts of the country. We can actually work in different parts of the world. And so families are becoming a lot more disjointed than everybody growing up and living in the same village. Interestingly, we actually are seeing a growth and a boom of multi-generational households in Canada, but particularly in places like Vancouver or Toronto, where housing prices are skyrocketing. And those decisions are being driven more from a financial basis as opposed to kind of a cultural basis that we should all live together. And again, there's been a growth in multi-generational households in these particular jurisdictions, mainly due to finances, but it's also the idea that the costs of housing are high, the costs of care are high, and when we don't actually have enough home and community care in place, or even affordable childcare, you can see why many people are now choosing to kind of try and do whatever they can to make ends meet, and that might be by packing multiple generations in a household together. But I think fundamentally, here's the problem: is that when we actually created our healthcare system in Canada back in 1966 under our Medical Care Act, that was our original sin, because we created a system that worked well for 27-year-olds. Why do I say that? The average Canadian at that time was about 27 years of age. And so if you think about the healthcare system a 27-year-old will actually need, they definitely need hospitals, they definitely need doctors, but we didn't include things like prescription drug coverage, what we call pharmacare, and we didn't include long-term care. But if you go over to Europe, they actually included all of those things. So when you actually go to Europe and they look at our Canadian healthcare system, they say, well, you love your Medicare, but your Medicare is kind of a bit skimpy. You're kind of missing some fundamental pieces that are really kind of key building blocks. And so our original sin was we never actually included the provision of long-term care, home and community care, and care in nursing homes, if you will, at the time. So it always was kind of this bastardized, part of our healthcare system, this orphan part of our healthcare system that kind of sat off to the side. And then lo and behold, we started aging. Back in 1966, most of us wouldn't make it past our 60s or our early 70s. Now our life expectancy is 82. And for those of us lucky enough to make it to 65, and most of us will, we have about 20 years of life expectancy ahead of us. But for those people who actually are living beyond the age of 85, but 1 in 3 will be living in a care home out of necessity. And partly that's because currently 430,000 Canadians right now tell us they have unmet home care needs. And if you can't actually get the care, publicly funded supports and care, if you don't have enough saved up to provide your own care, or you don't have family members around to provide that care, you don't really have much in the way of choices, and you end up in an institutional setting. And if we underfund that setting, then again, it just reflects to the fact that I don't think any of us ever anticipated that we'd grow old as a country. And now many of us will. Yet we actually have a system that doesn't actually meet the needs of an aging population. And frankly, all of us, this is kind of what we have to look forward to. So we need to fix this and get it right, kind of like the way many European countries have.
Mm. Do you think that there is, I've heard so much, debate about private care homes versus, public care homes, and there shouldn't be any private ones. I've heard some of the prices of, I know there's wait lists to get in. I've heard, some of my friends have told me what the prices are for some of these places. I just don't know how anybody affords it. Like, I really don't know how anybody, it's, to me, it sounds terrifying to age in this country.
Well, here's the challenge, right? So I think what people don't understand is, I think, as when we grow up, for kids or adults, for example, if we need, a hospital, it's always there. We never see a bill. The care's pretty good. If we need to go see a doctor, as long as we can find one, we're not charged a bill, for example. And so I think we're kind of coddled in this situation where we just expect that our needs as we age are going to be met. But just as you pointed out, right, for the average Canadian, who's entering retirement without a workplace pension plan. And what I mean by that is that only about 1 in 3 working Canadians actually has a workplace pension, for example. And so the rest of us are kind of left to our own devices to kind of save and kind of put money into RSPs and other things if we can. But the average Canadian retiring right now without a workplace pension plan is retiring with about $3,000 in the bank. Okay, that's the truth. So now you're living off of, Canada Pension Plan and old age security. Hopefully you qualified for those sorts of things, which gives you about just under $20,000 a year to live on, for example. So not a huge amount of money. And right now in Ontario, the way we design our publicly funded nursing home system, so our long-term care system, is we design it so that for those people who need basic accommodation, for example, you have to actually pay for publicly funded nursing home care. You're expected to, it's not a free ride, and you're expected to pay at least $62 a day, which you multiply that by 30, and that basically is designed to be the equivalent of what you get from basic government supports, right? So now if you had a little bit of extra money saved up, you might be able to get a semi-private room where you have a roommate, or a private room if you can pay $20 extra a day. So that's kind of how it works, in our publicly funded nursing home system. But of course, we do have an entire side industry of what we call retirement homes in Ontario. Other places they're called assisted living facilities or other things. And those are completely private. And those places start, remember, a publicly funded option starts at $1,800 a month. But a private home in Ontario is at least $3,500 a month. That's just room and board. You're paying rent. It's a landlord tenancy. And we have some homes in Toronto, for example, that are charging $12,000 a month, for example. So again, when you say, like, who can afford that? Yeah, the majority of Canadians actually can't. Some who are very lucky, who might have, sat on a home that appreciated a lot of money, can sell it and then can buy whatever they want. But the reality is the majority of Canadians, as we age, will not be in those privileged positions. And then they're relying on a publicly funded system, which right now doesn't provide an adequate amount of home care, which then forces people into more expensive kind of publicly funded nursing homes. And you're right. Again, we have over 40,000 Canadians who are on the wait list for nursing homes, but we also have 430,000 Canadians and over who are actually telling us they have unmet home care needs. So it really speaks to the fact that we have an underfunded system that we never included in our Canada Health Act. And right now, the priorities of our publicly funded kind of long-term care system are really about institutionalizing people as opposed to caring for people in their own homes. And if we did more of that, just like countries like Denmark do, they don't actually have people living in hospitals waiting to go home or to nursing homes because they have a lot of home care available. And they actually avoided building any new nursing home beds over a 20-year period because, again, people were living in their own homes, provided they weren't homeless. They had their own beds, and we could just bring the care to them.
How do we fix this? What can we do? Those of us listening to you, what can we do to help move this forward, to change the way we look after our elder Canadians?
I think, if we take it from a selfish motivation standpoint, right? I think all of us, if you ask anybody where they want to age. So TELUS Health and our National Institute on Aging just did a study together. And it was a fun study to do. We did it in July. We polled over 1,500 Canadians, and we kind of just want to see kind of how the COVID-19 pandemic has actually maybe changed opinions and ideas. And really, it told us a few things. First of all, 91% of Canadians of all ages, but 100% of Canadians older than 65 want to age in their own homes for as long as possible. And they want to do everything possible to stay healthy and independent in their homes. Like, not rocket science. I think we're like, yeah, I get that. And here's the other thing. 60% of Canadians who responded to our survey actually said that the pandemic has changed their perspectives on whether they or they would want a loved one to be in a nursing or retirement home. So it really has shown how kind of our perspectives have really shifted and have galvanized to people wanting to age in their own places. And here's the nice argument about all of this, is that actually supporting more of that is actually cheaper for all of us, because this is not about then having to find land and build a facility. Again, we're lucky that most of us actually come with our own homes, where we're actually quite comfortable. I mean, we chose to live there. We decorated it in our own kind of crazy way that we think is particularly nice and lovely. And again, if we can actually, deploy, and staff a home care system and service that, again, today they're coming to my home, tomorrow they might be coming to your home. It works pretty well and efficiently. And that's why it costs half as much to provide people home care, people who are eligible to live in nursing homes, half as much to provide their care in their own homes as it is on a daily cost per case basis in caring for them in a home. And that's also avoiding the infrastructure costs. So I'll just give you one number to help you understand the economic value of this argument. Right now, out of 79,000 nursing home beds in Ontario, we have 30,000 or across over 300 homes that are in need of redevelopment, that need to be upgraded. And the government is also committed to actually building 30,000 brand new beds on top of that. 60,000 beds, at over $200,000 per bed, just in just to build the bed, not even operate them, is about a $12 billion investment, right? So just gives you a sense of the dollars and cents that we're talking about. But here's the good news, that what we started doing in Ontario when I helped develop the government's senior strategy back in 2012 was we actually looked to Denmark. We said, wow, Denmark kind of really nailed it. They listened to the people, number one. They actually realized that, wait a minute, it's cheaper to care for them in their own homes, and that's what they want. Let's do it, right? And especially, if we have a fiscally conservative government, or a government that doesn't really care about finances, but just wants to give the people what they want. It doesn't matter what political stripe you are. This fits with any political philosophy. And what we started doing in Ontario was we actually were able to fund 30,000 more individuals to actually live in their own homes. So we're talking about people 75 and older who wanted to stay in their own homes with government-funded home care. We actually allowed 30,000 more people over a 4-year period to actually have that by investing more in home and community care. We didn't build a single new bed during that period. We allowed 30,000 more people to live. But that never really got any headlines, if you will. But the key is that when we're looking at building 60,000, new beds, redeveloped beds for $12 billion,
Yeah.
Again, it shows us that it is possible to kind of, implement the Denmark approach here. And frankly, it'll create a much more financially sustainable future for us all.
Well, and I mean, haven't we learned during this pandemic also that with digital health, we now have access, if we can make sure that, people have access to, and many people, have, like my mom is, in her 70s, my mother-in-law is 80, they have phones now, their iPads, they can see a doctor from their living room if they're worried about something.
Yeah, no, we have virtual care tools that really it was taking it forever. Like I was doing telemedicine, what we call it, prior
Right.
to the pandemic, for example, but I was kind of one of these rare docs doing this kind of type of care. And now, literally like within a 2-week period, when you realize the only way you can make money as a doctor is by dialing people up on their
Yeah.
phones and actually frankly being enabled to do that by the government by it was amazing that we went from maybe a small minority of doctors doing this to now every doctor now well versed in how to deliver virtual care. It explains how much we've really transformed the way we can provide care. And I think it really is when we've galvanized the fact that many people rather be in their own homes and now
Yeah.
tasted kind of what the comfort of virtual care can look like. It's not right for everybody in every situation, but certainly it gives us more options and tools and helps us understand what our future types of care could look like.
Hmm. Before we get into the risk assessment tool, that I want to talk to you about that. But first, at TELUS, they believe in doing business and doing good in our communities go hand in hand. And on behalf of TELUS Talks podcast, we wanted to let you know that we'll be giving $500 on your behalf to Haven Toronto, also known as the Good Neighbors Club.
It's one of my favorite charities, and they specifically work with older homeless men and do incredible work, especially during the pandemic. And again, we've been talking about people who actually have homes today. Just imagine how hard it is dealing with a pandemic if you're an older man who doesn't even have a home to begin with. So thank you. I just want to say thank you for supporting this organization, because I think a lot about them and their work, especially as I do mine.
You brought up another thing. Before we get into the risk assessment tool, if I can just ask you one question, and we don't have to get into a big discussion about it, but do you think the way that, because again, this is a whole other topic, do you think the way that we treat, pay, employ the people that care for our seniors and disabled Canadians in these care facilities, do we need to change that, the way that we do? I feel my personal experience has always been that many of these caregivers are treated poorly and paid poorly. Many of them have to have 3-4 jobs just to make ends meet. And they are not treated with respect. They're not a doctor. They're not a nurse. They're not this. They're not that. They're just somebody who's, around to care. Do we have a problem there?
We have a huge problem. I mean, the short answer is that we have a massive problem, because partly, first of all, if we don't really care about those who are older people in our society, why would we care about anybody who actually devotes their life to caring for them in the first place? And really, when we actually think about the majority of the care, it's hands-on, personal care. It's not easy care to perform. And it's largely done by what we call personal support workers or care assistants or personal care aides. A lot of names for them, but these tend to be mainly women. They tend to more likely be immigrants or racialized women. And frankly, we actually pay them far less to do this as home care workers as opposed to doing this in nursing homes. And both of those groups are paid far less than if they were to do that work as a personal support worker, for example, in a publicly funded hospital. So it really tells you that, we're not even talking, and that really kind of reflects the fact of how much we value certain parts of the care system. Because if we actually paid everybody an equal wage, it doesn't matter where you work, but we recognize that that work is valuable wherever you are in the system. This explains why the average person only lasts 18 months in one of these jobs, for example. And this is the challenge. When most of our homes across the country, and especially in our home care sector as well, are having trouble recruiting and retaining staff, then how do we expect to actually build a long-term care system or build any new beds when we can't even staff the ones we currently have? So do we have a problem? Absolutely. And part of the problem is because we underfund the system to such a large extent, we have too few people caring for too many people, if you will. So in Ontario alone, they actually said if we actually meet the basic standard that an expert committee appointed by the government said needs to be upheld, which was giving everybody in a long-term care home, a nursing home, 4 hours of care a day versus the 2.7 hours of care a day that they're currently receiving, that would cost us $1.6 billion more just to kind of be able to deliver the standard of care we expect that we should be able to give in these settings. So, yeah, I mean, that was a short answer, but the key is we have a huge problem that if we actually are counting on people to do this kind of work in future, we've got to see them, we've got to respect them, and we can't cheap out on them as well. This is hard work that a lot of people don't want to do, and it's dangerous work as well. Many face injuries in the workplace. So if we expect that we pay firefighters, for example, police officers who are people that we think are commonly working in dangerous positions, this sort of work is actually more dangerous, believe it or not, than the work of police officers and firefighters. And therefore, we need to value this work. We need to respect it, because otherwise, who would ever want to take a job in these settings if we don't actually see these people and pay them accordingly for the good work they do?
I agree. I couldn't agree with you more on that. That is, it's, yeah. I mean, think about, I just say to anybody, think about yourself being elderly one day and who will be looking after you. And don't you hope that that person is happy and paid well for what they do, and you have a connection with them and you care about them and they care about you. So it really comes down to that human connection. We're all people and we do need to look after each other. Just quickly, your risk assessment tool. So you're about to launch this new tool to calculate the risk of visiting people. Explain that to us.
Absolutely. So one of the main questions I get as a physician is kind of, how risky is it for me to visit, kind of a loved one, because we're thinking about having a gathering this weekend. We're thinking of having a few people, and what can I do to lower my risk of getting COVID? And because if you get COVID, there's a risk that you might die from COVID as well. So our team at the National Institute on Aging, we've actually are putting our finishing touches on a tool that we will be launching shortly at www.covidvisitrisk.com. And basically, it's a pretty simple tool. You just simply go in to a web page. You basically answer some questions about who you are, because we want to know, for example, there are things that make you at increased risk of getting and dying from COVID. For example, your age, for example, believe it or not, your sex. Understanding kind of if you have any chronic health conditions, for example, but also understanding the nature of the visit, because sometimes people say, well, I was thinking of taking public transit versus walking on my own. There's actually a different level of risk, from just how you're going to get there to when you get there, what are you going to do? How many people are involved? Is it indoors or outdoors, for example? What kind of activities are you going to be partaking? What sort of risk modifications can you do, like wearing a mask, staying physically distanced? And altogether, by just answering those questions, it doesn't take very long to input kind of what you think. This is what we're calling a decision aid, that you just simply press the button, and then it'll actually tell you your risk. It'll tell you if this is considered a low risk, a medium risk, or a high risk visit, for example. And it provides you at the end of the day with some education. So you understand, what you could do or what makes that visit more risky, for example, and what you can actually do to lower the risk of visiting with others, especially if you do want or need to visit others. And so that's a valuable tool that we think will be helpful. It's been designed in collaboration with a lot of leading infectious disease and experts and epidemiologists who've helped us, kind of scour the evidence, number one, so we can give people accurate, clear information, but then expert guidance, because it's as if you could actually ask your friendly neighborhood infectious disease specialist or epidemiologist saying, so that party with 500 people indoors where we're all actually sharing food, like that's a low risk thing, right? Well, no, this will actually tell you probably not. And probably if you do things with a much smaller group, and you do it outdoors, etc., these are things you can do to modify your risk. But of course, this is doing this all within public health guidance. So we're really excited to be launching this tool. It'll be the first kind of its tool that we know of anywhere in the world. And it's one that we hope that can actually help people make better decisions, because this pandemic isn't going anywhere soon. And I think for a lot of us, we have these decisions that are weighing on our minds. And if we can empower ourselves with the best possible knowledge, we can allow ourselves to make better decisions that can not only better support ourselves, but each other.
You've provided a lot of information here, really useful education on how we look after each other as we age in this country. I can't thank you enough for your time. It's important. It's an important subject, a really important subject that we all need to be thinking about. You're on Twitter, right? Dr. at Dr. Samir, that's DrSamir SINHA, at Dr. Samir Sinha. Thank you so much for your time today. Really appreciate it. Thanks for listening to another episode of TELUS Talks with Tamara Taggart. Be sure to subscribe so you can join us every Tuesday for another conversation. You can also check out our website, telus.com/podcast, and subscribe to our YouTube channel at TELUS Talks.